My absolute pleasure to introduce one of the coolest professors I know, talk about one of the coolest diseases I know. So Khalil Ghanem is a professor of medicine in the Division of Infectious Diseases at Johns Hopkins University School of Medicine and the Deputy Director of Education for the Department of Medicine on the Johns Hopkins Bayview campus. He is the program director of the Graduate Training Program in Clinical Investigation at the Johns Hopkins Bloomberg School of Public Health. He has been the principal investigator of the CDC-funded Johns Hopkins STD HIV Prevention Training Center since 2014. His research focuses on reproductive tract infections, in particular syphilis and the vaginal microbiome. He is the current president of the American Sexually Transmitted Diseases Association, and today he will be speaking to us about the coolest spirochete, syphilis.
Thank you. Thank you. It's a pleasure to be here. Thanks so much for the invite. I'm delighted. I always love to talk about syphilis. Nobody ever wants me to talk about syphilis, so it's always a delight to be asked to talk about syphilis. I'm going to share my slides with you all. And if you have any questions, don't hesitate to put them in the chat. And whenever there is a break for the next section, I'll try to answer any questions that are there. And I am going to maximize this and get started. So we're going to talk about syphilis in 2022. And the assumption that I'm making here is that most of you have some background in sort of the natural history of syphilis. And that's why I'm going to go, I have a lot of slides, but I'm going to go fairly quickly and highlight some of the things that I find particularly interesting and often particularly frustrating about the management of syphilis. I speak fast, I apologize, but I've always done that. And so you can slow me down if this is recorded and you're watching me on the recording session. So my disclosures as it pertains to syphilis is I do get royalties from UpToDate. I have written on STIs, including syphilis, for UpToDate. The objectives of this talk is really to identify dermatological and other clinical manifestations of syphilis among non-pregnant adults. And here, the caveat is I'm not a dermatologist. I'm an infectious diseases physician, and I always rely on dermatologists often in helping me make certain diagnoses. And often, I get a lot of referrals from the dermatologists in the US for patients that have been diagnosed with syphilis and complications from syphilis. So again, I will acknowledge that I'm not a dermatologist. And then we're going to describe the epidemiology, diagnosis, treatment, and prevention of syphilis. And there's some new data on the prevention that I think are interesting and worth highlighting. So that's our goal for today. And hopefully I'll be done early and we can take some questions. Again, feel free to add your questions into the chat if you have any questions. This is the natural history of syphilis. And I know you know this already, but I want to highlight just a few things. The first thing that I want to highlight is keep in mind that after exposure, this organism actually becomes systemic and penetrates the central nervous system in at least 40% of persons. And so here I highlight the issue at least 40% of persons because the studies that were done, they use the initial studies that use the rabbit infectivity model, and that has a very low sensitivity. And even PCR for neurosyphilis, when using PCR on the CSF, does not have great sensitivity. So at the very least, 40% of people already have the organism in their central nervous system, and I would argue that it's probably a higher number. And I think that's important to keep in mind. And the reason why I highlight it is because no matter when you see a patient with syphilis, whether they have early, very early primary, secondary, early latent, or whether they have late disease, whether it's latent or tertiary, then what you need to keep in mind is that they could potentially have neurological, ocular, or otic manifestations during that time. So it's really critical whenever you see a patient with syphilis to make sure that you rule out at least symptomatic neurosyphilis, otic syphilis, and ocular syphilis. And now you understand that the reason why these manifestations or these sequelae can occur even before primary syphilis is because this organism has already reached the central nervous system very early on, even before the manifestations of primary syphilis. The other thing that I want to highlight when we talk about syphilis is that these are, and this slide describes the clinical manifestations of syphilis, but keep in mind that when you have a recurrent infection, and there are studies going back, I'm going to say centuries, and recent studies that really recapitulate the finding that recurrent syphilis often is maybe asymptomatic. And so when somebody has an infection, is treated, and then they get reinfected, the second bouts and third and fourth bouts, they may be less likely to cause symptoms. And so asymptomatic reinfections happen, and they happen not infrequently. So this is syphilis, early invasion. Then you get the primary chancre, and we're going to go over these manifestations in more detail with pretty pictures. And the primary infection presents usually as a chancre with regional lymphadenopathy. And following that, the immune system kicks in, clears, and it's a regional immune reaction. Remember, the treponeme has very few external proteins, so it takes a while before a systemic reaction or response occurs. And then the chancre usually clears within a couple of weeks. And then you go through a phase where there are no signs or symptoms. And remember, these phases where there are no signs or symptoms are called the latent stages. And latency can either be early, and I know the UK and Europe may define it differently than the US, but in the US we define early latency, meaning the stages during the first 12 months after infection. Some places define it as the first 24 months after infection. Doesn't really matter. Ultimately, during that time, during the first 12 months after infection, when there are no signs or symptoms, the patient is in early latency. And then after 12 months, the patient is in late latency. And then after primary infection resolves, you go into a phase of early latency, followed by secondary syphilis, which has all the incredible clinical manifestations, and we'll go through those in detail. And again, the immune system now kicks in and clears it, and we continue our early stage until 12 months when we go into the late stages. In the past, we used to describe nearly 25% likelihood of relapse if patients are not treated, relapsing from latency into secondary syphilis. I'm not sure we see that as much in the antibiotic era, but it certainly can happen. Relapse rarely occurs and does not occur when you get into late latency. So the likelihood of relapse really does not happen after 12 months or so following infection. You go into a late latency phase, and at that point, about 70% of people who are never treated for syphilis will never have a problem again, whereas the other 30% will have tertiary or late manifestations. And we'll talk about those in a little bit more detail. Keep in mind, though, again, I want to highlight this because it is really critical every time you see a patient with syphilis to make sure they don't have neurological, ocular, or otic manifestations, no matter what stage of syphilis they're in, whether they're early stages or the late stages. So make sure you don't miss that. Keep in mind also that sexual transmission of syphilis really mainly occurs in primary and secondary syphilis. It does not occur after that. There are some case reports of transmission in early latent, but really sexual transmission doesn't occur in late disease, whereas vertical transmission can occur during any stage of the infection. That's why it's so critical to treat pregnant patients whenever they come in immediately, quickly, to prevent the consequences of vertical transmission of syphilis. And so that's also critically important. So now let's talk about the stages in just a little bit more detail. And primary syphilis, usually the chancre appears 2 to 3 weeks after exposure, but there's a broader range. And what I think is really critical is that in textbooks, it's described as a painless, single, indurated ulcer that usually has a clean base. While you see some of those here on these slides, you also see some more atypical presentations. For example, here, where you see multiple ulcers that are located on the patient's penis here. And up to 40% of patients will have multiple or painful lesions. So I think that's really important to keep in mind. And it can be very difficult. There was one study that tried to see how good we are clinically at distinguishing between herpes, syphilis, and chancroid, and we're not great at it. I mean, when it's classic, but often it's not classic. And so keep that in mind. And then usually the regional adenopathy tends to be rubbery, painless, and bilateral. And the primary syphilis tends to occur wherever the initial site of inoculation has occurred, and that could be the genital tract, it could be the anus, or it could be the oral the oral cavity, the lips, the tongue, the cheeks, the inner cheeks, etc. So keep in mind that this is not essentially secondary syphilis. This is primary syphilis. These are the primary chancres of syphilis. I will show you the mucus patches later that are characteristic of secondary syphilis. Also keep in mind, and I don't want to forget to say this, is that you can see overlapping stages of syphilis. And this is particularly true in persons who are immunosuppressed. For example, people living with HIV, they can have overlapping stages, primary overlapping with secondary. And so you can see the primary lesion and secondary manifestations. I've also seen that rarely in patients who are not obviously immunocompromised, but it tends to occur more frequently in those who are immunocompromised. Now, this is the paper that reminded us that atypical manifestations of primary infection may not be so unusual. And that's the Jenna Towns paper. It's a series from Australia. And they found that primary lesions were frequently painful in nearly half their patients, and or multiple in about 40% of their patients, and not usually associated with HSV. You would think that it's HSV that's doing that, but in the majority of these patients, it was not associated with HSV. This is not the first study to show this, but it was a nice reminder in the modern era to remind us that it's not always typical, and in fact, in many cases, it's not typical. And then we get into secondary syphilis, and secondary syphilis is truly phenomenal. And I've tried to summarize in this slide the various clinical manifestations, and I know you can look at it and see that there are deficiencies. Almost every organ system is involved. I didn't even include the heart and the vessels, and there's some recent data where they did PET scanning that showed that there is significant inflammation in the ascending aorta in secondary syphilis. And again, things that we weren't aware of until these novel modalities of imaging became available. And once you treat somebody, that inflammation tends to die out, but it certainly tells you what could happen in untreated patients later as the sequelae in tertiary syphilis. And so just as a reminder, I'm going to focus a lot on the skin, mucosa, and lymph nodes, lymphadenopathy and secondary syphilis in up to 80% of patients, rashes in up to 75%, but it's less when you get into recurrent infections, mucus patches, which I'll show you, which occur in up to a third of the patients, condyloma can occur in up to 20%, and alopecia in up to 5%. Although I have to say, I haven't seen alopecia in a while, but you guys may be seeing more patients with alopecia. I'd be intrigued to figure out whether that's what you're seeing or not. So with secondary syphilis, the rashes, keep in mind that there are the early rashes of secondary syphilis and the late rashes of secondary syphilis. The early rashes of secondary syphilis, first you start with a macular rash, and the macular rash usually spares the face, and it is evanescent. It's a short-lived rash, usually for 2 to 3 days. It's present if it's observed. It is usually non-pruritic. The treponemes usually are not present in macular lesions based on dark field microscopy. I haven't seen good data on PCR, the use of PCR in that setting, but then that is followed, that macular rash is often followed by a papular eruption, and that's the one that we usually talk about, which tends to be symmetric. It appears on the trunk, the extremities, including the palms and soles. Again, it's not a universal finding, but when you see it, it should certainly elicit the thought of syphilis. It is usually scaly, but it could be smooth, follicular, or pustular. And this is a nice review from 2005 that shows, that sort of delineates the dermatologic manifestations of syphilis. It's a lovely review. These are pictures of some rashes, these early secondary rashes that involves the palms and soles. I don't remember who took these pictures. It's either me or Jonathan Zendelman or Anne Rampalo, and one of them is from the CDC. So I've put everybody here just to cover myself. Again, these are some of many of the clinical manifestations. These are the mucus patches, and these are the late secondary dermatologic manifestations of syphilis. You tend to see them after the papular rash has become evident. And these mucus patches are found in the anal canal. You can see them in the vagina. You can see them on the lips, tongue, the oral cavity. And they are teeming with spirochetes. They are full of spirochetes and highly infectious. Again, these are late secondary manifestations of syphilis. In addition to that, we have the late manifestations that include condyloma lata. These are warts. They very much can resemble HPV warts, but they tend to be a little bit more flat and they tend to be more moist than HPV warts. Again, they are teeming with spirochetes. What's really fascinating, I've seen some really horrible cases of condyloma lata, particularly among immunosuppressed patients, mainly patients living with HIV. And it's amazing that when you treat them with a single dose of 2.4 million units of benzathine penicillin G, they melt away very quickly. And so it's quite striking. You can also see patchy alopecia, which is also seen as a late manifestation of secondary syphilis, as a late dermatologic manifestations of secondary syphilis. There are many atypical manifestations of secondary syphilis. That's why whenever we refer a patient to dermatology with a rash, dermatologists are brilliant. They always check for syphilis because they know that it can look like anything. This is a beautiful paper that was published in 2016 that sort of highlights some of the more atypical manifestations, where they show some of the late manifestations, such as the nodular, the annular, the pustular skin manifestations. Lewy maligna is something that we see mainly in persons who are immunocompromised, living with HIV, etc. And this is a mild case of Lewy maligna. It can sometimes be associated with central nervous system manifestations. Again, it tends to occur in patients who are immunocompromised, and there are terrible, I've seen a few terrible cases of Lewy maligna, so keep that in mind. And so again, it can really present, secondary syphilis can present like anything. And so whenever you see somebody with a rash, keep in mind the risk factors and the possibility that this could be syphilis. Now, there's a beautiful paper that was written, and I'm totally biased here because it was written by the reason why I went into syphilology was because of Dan Musher. He was one of my early mentors at Baylor College of Medicine. And Dan is an expert at syphilis. And he wrote this beautiful paper called Secondary Syphilitic Lesions. If you've never read it, you should read it. It's fabulous. It was published in Clinical Microbiology Reviews back in 2005. And it really just focuses on the secondary syphilitic lesions that you see. And it highlights some important concepts, and I've put them here in red. And this is a quote directly from the paper. They have beautiful tables, some figures. It's worth downloading, and it's freely available. And so I'm going to read this verbatim from Dan. Irrespective of how the lesions of the second stage of syphilis are classified, it's important to remember that they represent different stages of a single process and are not independent lesions or mutually exclusive of one another. That's really critical. And then he adds, in general, the histopathologic picture of all lesions, irrespective of the classification, are essentially identical. And I remember reading it the first time when he published it back in 2005 and thinking, oh, what a great paper. And then I didn't read it again until I was preparing for this talk. So it was really nice to go back and rediscover Dan's fabulous paper. Again, I'm biased. Dan was my mentor and is the reason why I went into this field. And so I would encourage you to read it. I do want to highlight one thing that people tend to forget, but you might encounter when you're taking care of patients with secondary syphilis, and that's syphilitic hepatitis, which may occur in up to 10% of patients who have secondary syphilis, but it's rarely detected because most cases are asymptomatic and we don't obtain liver function tests. But in case you do, it's important to keep in mind that syphilitic hepatitis usually presents with a disproportionately high alkaline phosphatase level and a mildly elevated AST and ALT level. So if you see somebody, it's not the only condition that does that, but if you see that in the setting of a rash, you should consider the likelihood of syphilis because you don't want to miss that. And there's a clinical association with rashes in secondary syphilis and hepatitis, as well as with anorectal lesions thought to be due to the organism in the anus and the drainage that goes from the GI tract and may involve the liver. So it's good. The thing to keep in mind with syphilitic hepatitis, in rare instances, patients may be symptomatic, but the thing to keep in mind is once you give 2.4 million units of benzathine penicillin G, it will dissipate completely. I had a patient who had a massive, what appeared to be, had a history of hepatitis C, came in complaining of right upper quadrant pain, was found to have a massive mass in his liver, and was found to have a rash on his palms and soles. They identified secondary syphilis, had a high RPR titer, and they treated him, but they thought that the mass, they did an ultrasound, and it was this huge mass. They thought that it was most consistent with cancer. He used alcohol in addition to having hepatitis C. He was scheduled for a biopsy the following, about 10 days after his visit to the emergency room. He showed up for the biopsy. They did an ultrasound. The mass had completely resolved. And it was, in fact, syphilis. It was syphilitic abscess, which can occur and will melt away with the treatment of early syphilis. So a fascinating disease, really. Now we'll move into the tertiary or late manifestations of syphilis, and cardiovascular syphilis is one such manifestation. We see it very rarely now in the antibiotic era, mainly because I think a lot of people take antibiotics for other reasons, and they often take a beta-lactam or a macrolide or a tetracycline, which has some activity against syphilis. So we're not seeing a lot of the tertiary manifestations, but they do occur. We saw 2 cases in the last year of cardiovascular syphilis at Hopkins. Again, it tends to affect the ascending portions of the aorta, but in rare instances, rarely, it can affect the coronary arteries, and the average onset is about 15 years after initial infection. The late benign syphilis is something that would interest dermatologists because, again, rarely you might see patients with a dermatologic condition presenting where they wind up having late benign syphilis. It affects the skin in about 70% of patients, but remember, it can also affect the cartilage, the bones, and then the viscera. I had a patient, several patients with gummas in the brain. I had a patient with a gumma in the liver, one in the spleen, one in the heart. So it can affect visceral organs as well. The skin manifestations tend to occur about 3 to 7 years after infection. And remember, these are individuals who are not treated because once you treat somebody with appropriate antibiotics, you abrogate the progression of syphilis. And then the manifestations of tertiary syphilis and late benign syphilis in particular, usually they're granulomatous nodules that coalesce, and then they can also form psoriasiform plaques and then gummas at the end. And gummas are usually painless, firm, pink to red, but then they can sometimes ulcerate and cause these destructive lesions that you see. And when they heal, it can be usually associated with scar formation. And so, again, you as dermatologists may see patients coming in with primary, secondary, or late benign syphilis. And so keep those manifestations in mind. The tertiary manifestations also include neurological manifestations of syphilis, and the neurological manifestations, as we've talked about before, can occur during any stage of the infection. Usually, Early neurosyphilis presents as a meningovascular form of syphilis, so it affects the meninges or the vascular system. So patients can present with a basilar form of meningitis involving the cranial nerves, or the patients can have involvement of the blood vessels, so they can present with strokes. The last patient that I saw was a patient living with HIV, not on antiretroviral therapy, came in with a seizure, turned out to have a stroke. He was a young man, and the stroke was the result of early neurosyphilis, meningovascular form of neurosyphilis. The late manifestations, CNS manifestations of syphilis can also be meningovascular, and the strokes tend to involve the middle cerebral artery, but they can also affect the parenchyma of the brain or the spinal cord. If it affects the parenchyma of the brain, usually it's referred to as general paresis, and can be associated with a myriad manifestations, including cognitive decline, such as dementia, personality changes, hallucinations, schizophrenic like symptoms. It's a very broad clinical spectrum. Or if it affects the parenchyma of the spinal cord, particularly the dorsal columns in the spinal cord, one can see TABIs with shooting pains in the back, gait abnormalities, etc. One of the things to keep in mind with syphilis, and I'm going to forget to say it later, so I'm going to say it now. The goal of treatment is to prevent progression of the infection. And you hope that there could be some reversal of the clinical manifestations, but that's not always the case. So what you're trying to do is prevent the progression of the infection with syphilis. And if you're lucky, and if these manifestations have been shorter lived, then you can sometimes see improvement in the clinical manifestations. I get a lot of questions. I treated this patient who had neurosyphilis, they're not getting better. And I always ask, are they getting worse? And the answer is no, they're not getting worse. They just didn't get much better. And I keep reminding people that it's really the goal is to treat to stop progression. And that's why it's so important to identify patients with syphilis early on to prevent there from being irreversible manifestations. Just to highlight that ocular syphilis and otosyphilis are distinct entities from neurosyphilis, but they are treated the same way. They're treated with 10 to 14 days of IV penicillin. Otosyphilis can affect patients, the inner ear of patients in single ear in 50%, both ears in 100%. Always ask about the possibility of new onset tinnitus, hearing loss, vertigo or dizziness, and instability. And that's otosyphilis. And then ocular syphilis can affect any part of the eye, from anterior to posterior, can occur like otosyphilis and neurosyphilis during any stage of the infection. And with ocular syphilis, it can affect the eye in one eye in 50%, both eyes in 100%. Keep in mind that up to 40% of patients with ocular syphilis will have a normal CSF exam, and up to 90% of patients with otosyphilis will have a normal CSF exam. And so you don't need to do a lumbar puncture to make a diagnosis in patients who have ocular only and or otic only signs and symptoms. If they have neurological signs and symptoms, other neurological signs and symptoms, you should do a lumbar puncture. Keep in mind that a negative lumbar puncture in somebody who has presumptive neurosyphilis essentially rules out the diagnosis of neurosyphilis. The lumbar puncture is important because it can help you rule out the diagnosis of neurosyphilis, but ocular syphilis and otosyphilis, and negative or normal lumbar puncture does not rule out the diagnosis of either one of these. And so you still have to treat the patient for ocular syphilis and otosyphilis. And so the 2021 treatment guidelines from the CDC no longer recommend a routine lumbar puncture in patients who have oto or ocular syphilis, symptoms related to oto and ocular syphilis alone. So that's an important distinction between otosyphilis, ocular syphilis, and neurosyphilis. The epidemiology, I want to go quickly through the epidemiology because I think everybody knows that it's a mess. Wherever you look, in any country that has looked at syphilis, and I think I'm going to say I think in the vast majority of countries that have looked at syphilis, the rates are increasing to a fault. This is the United States. I'm going to start with the United States and then maybe give you some data on Europe. I apologize if I don't cover the area where you're from. I know this is an international audience, but I think if you look at your public health infrastructure, they can certainly provide some data. Hopefully you have some data. And in the United States in 1999, we reached the lowest level of syphilis, incident syphilis in history, at least since they kept track of syphilis rates. And the CDC came out with a national plan to eliminate syphilis in 99. In 2000, unfortunately, the rates of syphilis started increasing, and they have not stopped since 2000 in the United States. Right now, there are two different epidemics in the United States. There is an epidemic among MSM, and about 40% of those individuals are HIV co-infected. And that's an epidemic that had started in 2000 and has been ongoing since then. And then there is an epidemic in the heterosexual population in the United States. And that essentially started about 8 years ago and has been growing exponentially. Just to give you a sense, over the last 10 years, the primary and secondary syphilis rate among women in the US has increased nearly 700%. And among heterosexual men, about almost 200%. So we're seeing an exponential increase amongst heterosexual men and women, and a continued increase, albeit not as steep, among men who have sex with men. Congenital syphilis is a catastrophe, and it comes as a result of increasing rates in women, and we're seeing exponentially increasing rates in congenital syphilis. Between 2012 and 2021 in the United States, the number of cases of congenital syphilis increased over 700%. That is heartbreaking. It is a failure of public health, and it should not happen in countries that have easy access to penicillin and easy access to screening modalities. It's horrifying. The same thing is happening in Europe, although the data from Europe are lagging behind because of COVID, but we're seeing similar trends, although the heterosexual trend has not yet picked up as much as in the United States, although that might change when the recent trends become available. I looked at the European CDC, and the latest data they have as of a month ago was from 2018. So two epidemics, heterosexual, and then epidemic among men who have sex with men, increasing rates, really shocking, given that we have a drug, penicillin, that works really well. There's no drug resistance, and we have reasonable diagnostics for syphilis. And so now we can talk about the diagnostics for syphilis. And usually if you have a lesion, the best diagnostic is the PCR test. And the PCR test is not routinely available in all settings, but you still have dark field microscopy. And dark field microscopy is cheap. It's easy to do, but you have to have a dark field microscope. And most places don't have access to a dark field microscope. PCR is a useful test when there's a lesion. When there are no lesions, it's not particularly good. And so if you're lucky to have PCR, great. When there are no lesions, there's still some sensitivity, and they've detected Treponema pallidum in the saliva of patients, in patients even who didn't have any oral lesions. So it is sensitive, but beyond the primary and secondary stage, the sensitivity actually wanes significantly. And then dark field microscopy, keep in mind something very important. If you have a lesion in the mouth, you cannot do dark field microscopy because the gingiva, the oral mucosa, there are lots of treponemes, including Treponema denticola and other treponemes, that will show up looking like syphilis on dark field. And so it's a worthless test. It has no specificity when it's done in the mouth. It also has a very low specificity if it's a lesion that can be contaminated by stool. So if you have a lesion in the rectal area, you can't really do a dark field because if it's contaminated by stool, stool also contains lots of non-pathogenic treponemes. So keep that in mind. PCR can be used because it is specific for Treponema pallidum. Now, what we mainly use around the world are essentially serologies. And many people get confused by serologies, but there are only 3 rules for each of the serological tests. And if you know those rules, you can easily interpret the various permutations of serological testing. For the non-treponemal or lipoidal test, the RPR and VDRL, some places still use the TRUST test. Again, same story. With the non-treponemal test, they're useful because they give you a titer. I know that some places use IgM titers for treponemal tests, but in the United States, we don't use them. The only titers that we have are the RPR and the VDRL titers. And the RPR and VDRL antibodies, keep in mind, they're going to be non-reactive in 30% of persons with primary syphilis. So they can be falsely negative in early primary syphilis. You can have false positives, and there are many causes of false positives of non-treponemal antibodies. And keep this in mind, they may become non-reactive with or without treatment. So a negative RPR can mean that a person doesn't have syphilis. A negative RPR can mean that a person had syphilis in the past and was successfully treated. Or a negative RPR can mean that a patient had syphilis in the past, was never treated, and then the RPR came down. Or a negative RPR can mean that the patient has early primary syphilis. There are 4 different interpretations of a negative RPR, so keep that in mind. Those are the 3 rules for the VDRL and RPR. Whatever I say about the RPR applies to the VDRL as well. There are 3 rules for the treponemal test, and it applies to all of the treponemal tests, whether it's EIA, CIA, TPPA. They're going to stop making TPPA, which is a mess. They're non-reactive also in early primary syphilis. So patients with a negative TPPA and a rash of an ulcer of primary syphilis could have a negative treponemal antibody, so keep that in mind. You can also have false positives, but the causes of false positives are more limited, and they include the non-syphilitic treponematoses, they include Lyme disease, they include severe gingivitis. That was shown by a paper by Sheila Luckhart's group that was published in the New England Journal of Medicine in the 80s. And then the one thing to remember, and there's a caveat here, is that the treponemal test, once reactive, always reactive, independent of treatment history. That's not quite true. Patients that are treated very early on in primary syphilis, over time, they may lose their treponemal antibodies after 5-10 years. But in general, once reactive, always reactive. If you know these rules, you can interpret any permutation of diagnostic tests. So if it's a negative RPR, you think, well, the patient may not have syphilis. They may have early primary syphilis. They may have essentially treated old syphilis or old untreated syphilis. It could also be that they have a reaction, a prozone phenomenon reaction in secondary syphilis due to the high antigen load. And if you ask the lab to take the serum and dilute it, it will come back positive. So there are many causes of a negative RPR. And by knowing these rules, you can interpret the various permutations. This is a summary of how to interpret the various permutations in a table, and the same thing in a chart. So those of you that like charts, it's right there, and you can interpret them. And if you like a table, it was on the previous chart. Just use those 3 rules, and you'll be able to interpret all of these manifestations. Keep in mind that the goal of treatment serologically is to decrease the RPR or VDRL titers 4-fold. So you want to decrease the titers 4-fold, and usually once they decrease 4-fold or more, that's considered to be a serological cure. But you want to give them time. You want to give your patients time. If they have early syphilis and you're treating them, then you want to wait for a year until those titers come down 4-fold. Don't be in a hurry to retreat and overtreat. And then if they have late syphilis, you should wait 2 years for the titers to come down. And if the titers are very low, 1 to 1, 1 to 2, they may never come down. and that's okay. And so keep in mind that patients whose titers, it may take a while for those titers to come down. Give them plenty of time for the titers to come down. If the titers go up fourfold after treatment, then you have to consider the possibility of either treatment failure or more likely reinfection. Those are the possibilities. It's impossible to tell the difference between treatment failure and reinfection unless the patient presents with some clinical manifestation suggesting early syphilis, and so you need a history and a good physical exam to distinguish between treatment failure and reinfection. So keep that in mind. Just one thing to keep in mind, persons with HIV, their titers may take longer to decline. And so the CDC treatment guidelines suggest that in persons with HIV who have early syphilis, instead of waiting just 12 months, you can wait up to 24 months for their titers to come down. Keep in mind, this is as long as the patient is doing clinically better. So as long as the patient is doing clinically better, you can watch their titers coming down over a certain period of time. For neurosyphilis, there are two tests that usually I find very useful. First of all, it's not a very specific test. In fact, it's not specific, but it's the most sensitive parameter, and that's white cells in the CSF, usually lymphocytes. And that's useful. It's hard to make a diagnosis you should really think twice about making that diagnosis. It has been made, but rarely. The other most specific test, but not very sensitive, is the CSF BDRL. It is negative or non-reactive in about 50% of patients who have neurosyphilis. But if you find it to be reactive in the CSF, you can make a definitive diagnosis of neurosyphilis. There are treponemal tests that people use. The treponemal tests are very sensitive, but they're not specific. So if the treponemal test comes back negative, you can rule out the diagnosis of neurosyphilis in most cases. But if it comes back positive or reactive, you shouldn't make a diagnosis of neurosyphilis simply based on a reactive CSF treponemal test. So it is sensitive, but it is not specific, just like pleocytosis, unlike the VDRL, which is specific, but not sensitive. So how do we treat syphilis? Well, early syphilis is 2.4 million units of benzathine penicillin G, primary, secondary, early latent, 2.4 million units of IM benzathine penicillin G. Late latent is given 3 doses of that regimen 1 week apart. So 2.4 million, 1 week later, 2.4 million, and 1 week later, 2.4 million. If it's a non-pregnant patient and they cannot take benzathine penicillin for some reason, they have a terrible allergy, etc., you can use doxycycline for 2 weeks for early syphilis, and doxycycline for a month for late syphilis. Keep in mind that you should not be using macrolides like azithromycin. Even though they're effective, there's a lot of resistance that's been documented throughout the world, so avoid using macrolides for the treatment of syphilis. You can, for neurosyphilis, ocular syphilis, and otic syphilis, the treatment is 10 to 14 days of IV penicillin. That's the best. Ceftriaxone may be used as an alternate. Monty, who is here, it was one of the co-authors on a paper that suggested that high-dose oral doxycycline may be used at least in early neurosyphilis. I would not recommend using it because the data are still very limited, but there are ongoing attempts to do clinical trials. So in the future, we may be able to use doxycycline high dose to treat. I would not recommend it unless the patient says, I'm leaving the hospital, I don't want to get intravenous antibiotics. In that case, write the prescription. I'll highlight that in the UK guidelines, high-dose oral doxycycline is an alternate agent, but it's based on very limited data. The best data are from this study here. So if you're interested, call Monty and he will tell you all about that study. So that's the treatment of syphilis. Penicillin is the best drug. If you don't have access to penicillin, then you have limited other options. Ceftriaxone is reasonable for neurosyphilis, like we said, but penicillin is still the best. Keep in mind the Jerisch-Herxheimer reaction, which can worsen some of the dermatologic manifestations of syphilis. It is not a penicillin allergy. It really is an immunological reaction, a cytokine storm in some ways, as a result of the killing of the spirochetes. It tends to occur more frequently in early syphilis after treatment of early syphilis, but it has been described after treatment of late syphilis. There have been rare cases of patients who've had really serious reactions as a result of the Jerisch-Herxheimer, but in general, it's a mild reaction that can be treated with anti-inflammatory agents. One population to be mindful of are pregnant patients. If you have a pregnant patient, warn them about the Jerisch-Herxheimer when you treat them, and make sure that they understand that in rare cases, it can lead to early contractions, etc. Again, do not withhold treatment of pregnant patients because you're worried about Jerisch-Herxheimer. Treat all pregnant patients as quickly as you can. Just warn them about the rare possibility of the Jerisch-Herxheimer. If you're treating somebody with multiple doses of intramuscular benzathine penicillin G, so you want to give it, let's say they come in on a Monday, you want them to come back for the next dose next Monday, and then the following Monday for the 3 doses. If they're late, how long between days can they be late? If they're a pregnant patient, 9 days is the maximum between doses of benzathine penicillin. If they're more than 9 days, you need to restart the regimen. If they are individuals who are not pregnant, adults who are not pregnant, you can go up to 13 days between doses, and you don't necessarily have to restart the regimen. In Baltimore at Hopkins, we use a cutoff of 10 days for non-pregnant adults. So if they come in on day 11, we restart the regimen. If they come in within 10 days, we just keep going with that regimen. Keep in mind that that's for long-acting intramuscular benzathine penicillin G. Now, one of the things that you're going to be facing is, what do you do with patients whose titers don't respond appropriately to therapy? So you treat somebody, it's always really important to get a titer on the day of treatment. So get your RPR, VDRL titers on the day of treatment. That way you have a baseline, treat the patient, and follow the titers over time. If you've waited for 12 months or 24 months if it's late syphilis, and the titers have not gone down 4-fold, if they're still have not gone down 4-fold, here's my approach. Are there any neurological signs or symptoms, or ocular signs or symptoms, or otic signs and symptoms? If yes, if they have neurological signs or symptoms, perform immediate LP. If they have ocular or otic signs and symptoms, evaluate them and then treat them for ocular or otic syphilis. If they don't, and if the patient is either pregnant or the patient could have been reinfected because they tell you they've had exposures, just go ahead and retreat them for syphilis. Give them, depending on when the exposure happened, etc., you can retreat them either with a single dose of benzathine penicillin G, or if it's been more than a year, 3 doses of benzathine penicillin G. Is the titer at the time that you're evaluating them greater than or equal to 1:64? If the titer is greater or equal to 1:64, consider a CSF examination, because there was a recent study from China, not the best study, that suggested that higher titers increase the probability that somebody may have asymptomatic neurosyphilis. So consider it if the titer is very high. And then if everything here is negative, if they don't have neurological signs or symptoms, if they're not pregnant, if they have not been reinfected, if the titer is not higher than 1:64, if all of the above are negative, you can just watch the patient. The data suggests that it doesn't really matter if you retreat them or just watch them. What I usually do is I just watch the titers coming down. That's different from somebody who gets treated, whose titers come down, but then they go back up. If the titers increase 4-fold from the time that you see the patient, that you treated the patient, the first thing to do is, are there any neurological signs or symptoms? If yes, perform a lumbar puncture. Could the patient have been reinfected? If yes, treat them. If the patient denies any signs and symptoms, or the possibility of reinfection. And the titer continues to be elevated when you repeat it again 2 weeks later, then consider performing a lumbar puncture because the possibility of asymptomatic neurosyphilis is high. Not huge. Most patients will not have asymptomatic neurosyphilis, but it's high enough that it warrants consideration of a lumbar puncture. So now hopefully you know what to do with patients whose titers don't come down fourfold and in patients whose titers increase fourfold. And these are the studies that were done to suggest that in patients whose titers don't come down fourfold, that if you wait, you probably are going to be okay, and you don't necessarily need to retreat them. These are the studies that have been done. They're all observational studies. Who should have a CSF examination? Patients who have neurological signs or symptoms, patients who have evidence of tertiary syphilis, late benign syphilis or cardiovascular syphilis, because 30% of those will have essentially underlying asymptomatic neurosyphilis. And then consider in patients whose titers go up fourfold if they were not reinfected, or whose titers don't come down fourfold, assuming they meet the rules that I showed you in the previous slides. Doing routine lumbar puncture in persons with HIV, I think, is not warranted. If you feel strongly about it, you can. It's not a problem. But I think most people these days, most clinicians, are not performing routine CSF examinations in persons who are living with HIV, mainly because there are no data to suggest better outcomes. And so I don't routinely do it. Once you do a CSF exam and you make a diagnosis of neurosyphilis and you treat the patient, as long as the patient is doing better and their serum titers, VDRL and RPR titers, are coming down, you don't need to do any more follow-up CSF examinations. You are okay without any additional CSF examinations, as long as the patient is not immunocompromised and they are clinically doing better. If the patient is immunocompromised, doing a follow-up lumbar puncture 6 months after treatment is still recommended to make sure that the parameters are improving. And so keep that in mind. That's also a change from last time. Last section, prevention. Of course, screen. We do a horrible job of screening. The USPSTF just released their screening guidelines last week. And we do a terrible job of screening. And that's a huge problem. And that's one of the reasons why why the rates keep going up. Of course, when you screen, treat patients. Go after their partners. It's very difficult to go after their partners in the app age, right? When you meet somebody on an app, you don't know their names, you don't know where they live, there's no bar where you met them. And so it's very difficult to find partners in the geospatial app age. So it's become very challenging. If we don't screen, if we can't find partners, it's challenging to control the infection. This is a slide that essentially summarizes who and how frequently to screen for syphilis. And hopefully you'll find it useful. I'm not going to go over it in details, but I'm more than happy to share my slides. Just email me and I'll send you a copy of my slides. Find those partners. And this is a summary of how you should go about tracking partners down for syphilis. You want to treat the partners so that they don't reinfect the patient. Of course, the major drivers for the STI epidemics in general and syphilis, including syphilis, are poverty, stigma, and structural racism. I think stigma really drives everything in STIs. And until we can control stigma, which I think is very difficult to do, it's going to be really hard to control STIs. The other big factor that I don't mention here is money. You need a lot of money to control STIs. And unfortunately, in most public health arenas in the COVID era, there has been very little money allocated for the control of STIs. There's limited money in public health, and they're focusing on other things other than syphilis and other STIs. And until there's a lot of money spent, it's going to be hard to control this epidemic. I want to end by highlighting one study that was presented. It hasn't been published yet. That was presented at IAS, the International AIDS Society. It's one of the randomized controlled trials that we've been waiting for. The use of doxycycline as post-exposure prophylaxis for the prevention of gonorrhea, chlamydia, and syphilis. It was a randomized trial that randomized 324 patients on HIV PrEP and 174 patients living with HIV. The median number of sex partners that they had was 9. So they had in the prior 3 months. So it's a group that is at high exposure to STIs. And they essentially randomized them to routine care or 2 doses of doxycycline 24 hours apart, and essentially to see if doxycycline can act as a post-exposure for STIs. And what they found was that individuals who took the doxycycline after an exposure had far fewer episodes of gonorrhea, chlamydia, and syphilis. Syphilis was not statistically significant because the number of cases of syphilis was relatively small, and the DSMB stopped the study early because of the impact that the study was having. But I can guarantee you that doxycycline works fine to prevent syphilis. It was a successful study. 88% of the participants had favorable acceptability for that. Most of them took less than 10 doses a month. But unfortunately, there was a trend in increased tetracycline resistance in breakthrough gonorrhea infections. We don't use tetracycline to treat gonorrhea, but it's an issue. It's also an issue for example, MRSA. Tetracyclines are very useful for MRSA. Will it increase resistance to tetracyclines in MRSA? The answer is not quite known, but clearly doxycycline post-exposure prophylaxis is effective in a subset of patients. And there are uncertainty about the long-term sequelae of this, dysbiosis of the gut microbiota and other microbiota, but what that means is unclear. Resistome, the emergence of resistance, is a possibility, and so we have to be mindful. There are some metabolic consequences, including weight gain, particularly among those who use a lot more doxycycline. That's something to keep in mind. And then the impact on the microbiome can also lead to immunological impact. If you're going to use doxycycline in your patients to prevent them from getting STIs, it should be shared decision-making. You should talk to the patients about these uncertainties, and then you and the patient can make the appropriate decision about what to use, whether to use doxycycline in those cases. Ladies and gentlemen, thank you so much for your attention. I want to remind you, if you live in the United States, in the continental United States, you have access, free access to any questions about STIs through the NNPTC network. And this website gets you immediately an answer to any of your STI issues. And if you want to learn more about syphilis, there's the National STD curriculum through the University of Washington, and they do a beautiful job going over syphilis and the STIs. I thank you very much for your attention. And now I'm going to shut up. I went over. Thank you very much.
Thank you so much, Dr. Ghanem. We have a time for a few questions. So I'm gonna start them. I also want to say I'm a huge fan of doxy myself, and I think you are too. And it's interesting because in dermatology we use doxycycline quite a lot. So I just wonder whether we should do some research looking at the rates of syphilis in at-risk people who are on doxycycline, say for, I don't know,
acne,
pemphigoid or acne or something. But anyway,
Monty, I think you should.
Okay.
I really think you, because that's the only way we're going to be able to answer it, is to really, it's going to be through observational studies. It's really impossible to do it through a randomized control trial. So Monty, I'm tasking you with that. We love doxy, and it has been used safely, but it's a tough decision, and it should be shared decision making.
Yeah. There's a question in the chat by Gulsum. They ask, they say, great talk, thank you so much. If we think the patient is possibly has syphilis, but all the tests are negative, can we use empiric penicillin for treatment? Yes,
by all means. Remember, 30% of patients who have early primary syphilis will have negative serologies. And so if you think that the patient could have syphilis, I'm a huge proponent of treating empirically because the consequences of not treating are so high that it would be a shame to miss potentially a patient who will go on to infect other patients. So yes, great question. I would treat if my pretest probability for syphilis is moderate to high, even with negative tests.
And another question that's kind of plagued me for a long time is, I know you mentioned briefly about the secondary syphilis rash. Now we know mucosal patches and we know chancres and cutaneous lesions themselves are infective, but is the rash in itself infective? And if not, then what is the pathogenesis of that rash? Like, is it a vasculitic rash? What is it?
So it's thought to be, so that initial macular rash, right? That macular rash is thought to be an immunological reaction, right? It's an immunological reaction that's developing. But I would say that I haven't completely lost the suspicion that there may be involvement of the treponemes themselves as well. Most of the studies that have been done that I know of have used dark field microscopy on the rash, and they've not identified any treponemes through that. But having said that, I think using PCR, we may be able to detect rare treponemes that are found in the rash. Usually the rash, that initial macular rash is mainly driven by immunology as best we can tell. The papular rash may be to a large extent immunologic, although Musher in his paper, the 2004 paper or 2005 paper that Musher wrote, he suggests that it's the treponemes that are doing most of the driving for the papular rash and for the late rashes associated with secondary syphilis.
Great, thank you. And I think our last question is from Dr. Richmond, if she wants to ask live.
If she wants to ask my email?
No, I think she.
Sorry, I'm here.
Jillian, hi.
Hi, that was an excellent talk. My question is actually about the organ dysfunction essentially after tertiary syphilis. Is it because of the fibrosis, or is there like some sort of subsequent autoimmunity happening, or do we not like fully understand that?
It's actually due to inflammation usually. So it's the result of active inflammation that's leading to, now with the liver, there is a fibrotic component following the inflammatory reaction, but I suspect that there's a fibrotic component with almost all of the manifestations as a result of the inflammation that occurs in any of the organ systems, including the most important organ system, the skin. And so a great question, thank you.
Thank you so much, Dr. Ghanem. Thank you everyone for joining us. The recording will be on YouTube at some point.
Thank you all, take care, bye.